We'll begin. Good afternoon, everyone. I'm Mike Goucher. It's good to see all of you. Welcome back. Hope you had a great time over the holidays and got some rest and relaxation. It's good to have you back with us here at Marquette University Law School. This, as many of you know, is On the Issues, which is our continuing series of conversations with news and policymakers, people we say are doing important, interesting work in this region and beyond. Today we are joined by the City of Milwaukee's Health Commissioner, Bevan Baker. He has been in that job since 2004. He's been a member of our community since 2001, and we're delighted to have him join us at Marquette University Law School. Please give him a warm welcome. Well, let's talk about the flu, because that's personal for me. I thought we might begin by talking about what's happening in our community. Have we peaked yet? What are we seeing right now?
Well, I certainly hope so. Let me first say that, the only thing predictable about flu is the unpredictability. And we've had 2 mild years, and this year is a severe year. So what we're starting to see is a decline in the number of ED visits, emergency department visits. So that means we could be beginning to see that peak. Hospitalizations are still up. We expect them to go up even more because as people go to the emergency department, they're going to have more hospitalizations. Wisconsin didn't fare as bad as Minnesota and Illinois and Boston and other parts of the country, but it's still been about twofold more than we've had since going back to 2004, 2005. And it's a serious issue. So, although there's a lot of talk about its hype, well, if you've had a touch of the flu or the flu, it's not hype.
No, it's not. I can speak firsthand to that. Is the vaccine working this year? Is it working as well as people had hoped?
Well, I think first you need a few moments to think about the complexity of vaccine availability and what has to happen. Far before we began to think about influenza, great minds across this globe began to track strands of influenza that's happening in other parts of the world, and they try to hit the bullseye. They look at what's circulating, and then there's an incredible manufacturing process, and that process sometimes can be lengthy. Some say it's even dated because it's using old egg cell technology, but this vaccine is somewhat on the bullseye. It has good efficacy, a good efficiency, but there's a couple strands that are circulating. So it's never 100% perfect. But if you're in a class or cohort that could be adversely affected, your immune system, you're older, you're younger, then I would rather have the opportunity to feel miserable than to be dead.
Mm-hmm. That's a better option, I think. Are you still recommending the vaccine for people, or is it too late to get it now?
Well, I always recommend the vaccine. I think that when you look at any physical plant that's been built, you know that if you don't know anything about architecture, anything about building buildings, you assume that a hammer was used. Well, the influenza vaccine is the hammer for the medical community as we look at flu. It's the best thing that we have in our toolbox. And it's really saved tens of millions of lives. And if you go back to the early 1900s and you look at the Spanish flu, for instance, 50 million people succumbed to influenza. Think about it. And we didn't have 300 million people in the U.S. back then. If they had had a vaccine, then probably many of our forefathers and foremothers and much of our lineage would be different. So 50 million people succumb to it. So the vaccine, it's never too late to be healthy. It's never too late to get a vaccine. And I think outside of the photocopier, the vaccine is the most incredible invention in the history of mankind. And the only reason why the photocopier is more of a great invention, you were able to copy the information about the vaccine.
Is it possible that one of the explanations for why this flu bug seems to be a bit more prevalent this year, is it possible that we've grown complacent in terms of the vaccine, that because a couple of other expected outbreaks in years past maybe weren't quite as as hard-hitting as were expected? Did we just sort of grow blasé about getting the vaccine?
Well, and I don't want you to take this personally, because I know that your history of mass communications and media, but I think that the media has put a lens on us becoming complacent. When it's a severe year, we get countless cameras and lead-ins and stories about influenza. When it's a mild year, we in public health still do the same thing. We always leave a light on in terms of emerging infections. Yes, I think we become somewhat complacent. And I think in that regard, we've taken for granted most vaccine-preventable disease in this country because we live relatively safe and relatively healthy. If you go to developing nations, when they're putting polio into the mouths of babes to save tens of thousands, and those those workers who are putting the polio in the mouths of babes are being shot and killed because that vaccine is going to save people. We in this country have gotten complacent. So I do think that the lens of this digital democracy that we're living in, where you can see images and sound and video within seconds and milliseconds, if it's not hot, it's not real. But babies die. We've had 24 pediatric deaths. And as a parent, and anyone who is a parent, guardian, adoptive parent, grandfather, or has nieces and nephews, could you imagine one of your children succumbing to influenza because they didn't get a vaccine or because they didn't have access to a vaccine? No, you couldn't.
I want to spend a fair amount of time today talking about public health challenges facing this community. We'll spend some time on teen pregnancy. There's been some success there. We'll spend some time on the problem of violence and looking at that as a public health issue. But I thought we begin by talking about infant mortality. The one thing that I want to say first, before we get to that, though, is this. It occurs to me that prosperous communities are healthy communities. How strong is that correlation?
I think it's the most significant correlation of our time. Let me be extremely clear here. If a community, a city or state or a nation is not healthy, it's not relevant. And we can go back to the history of civilization. Any civilization that's not healthy is not relevant. And I believe that when health is present, then certainly the wisdom of a society can come through. But if health is not present, then there can be no wisdom. It's something we take for granted. So when we look at the one barometer that the whole world looks at in terms of how healthy a community is, how healthy a city or nation is, it's infant mortality. It's how babies survive. And when you look at southeastern Wisconsin, when you look at Milwaukee, a great city that it is, and we have rates of infant mortality that rival some third world nations, then how relevant can we be as a city? How relevant can we be as a state? And in the confines of a nation, how relevant can this nation be? We are only as healthy as our conscience.
Why do certain neighborhoods in this community have infant mortality rates the likes of which we see in third world countries, or worse than we see in some third world countries?
I think first I want to do due diligence to the complexity of infant mortality and the challenge of infant mortality reduction. There are some great people, even here at Marquette University, who are working on this issue. And we know that most of the infant deaths in this community happens because of prematurity. And that happens through marvels that even the best geneticists, the best physicians in the world can't understand what happens in utero. But we also know that there's other percentages of infant deaths that are 100% preventable. And while controversial in terms of how we go about that prevention, they're still 100% preventable. So we don't know. But I do believe if you were to pull back the layers and make all this world of noise quiet for a moment, that you would understand that if you go upstream and deal with social policy, housing policy, income policy, racism, all of these issues, then you will begin to get to some of the underlying issues that make for the perfect cocktail that allow Milwaukee to fare worse than other entities. Because some communities have dealt with income inequity, housing inequity, employment issues. They've dealt with race in different ways. that Wisconsin and Milwaukee hasn't. And let's be candid about that.
I want to follow up on that because I want to talk to you about this prematurity issue that you mentioned and also the co-sleeping problem that we hear so much about. Let's talk about the prematurity thing. When I hear you speak to that issue, it reminds me of something that was said about a little over a month ago. Some of you may have even been in this room. Paul Tough, who's an author and has written an excellent and provocative new book about character and why that's so important in our kids being educated today. He said in research he'd done for that book, he talked to scientists who said one of the reasons why kids were not succeeding in the field of education is because of the stress, the impact of stress in their lives, chronic stress, chaotic environments in which they live. I think I hear you saying some of the same things, that has an impact on this tendency to see premature births in this community.
It is tremendous. I think if you go back even to the Renaissance time, go back to the Baroque period, when we see all the majestic nature of civilization, when someone was with child, the whole community rallied around her. She was treated as a queen almost. And if you grew up in a community where, one, you are worried about, do I have enough money to eat? Do I have housing over my head? There's bullets flying around. I am looked at as a second-class citizen, maybe because the hue of my skin or predetermined issues when I walk into a room. All of that stress on a woman. You know, I was struck a few years ago. I was out at State Fair Park, and I was walking through the livestock area, and there was a calf being born. And I looked at this young girl, and she had tears in her eyes. And it was an incredible thing to see this calf being born right there. And I looked over at her father, and I said, that must be great. He said, she's been there every minute, waiting for this calf to be born. So if that, and you think about what this young girl had done to make certain that calf could be born healthy, and that's an animal. What are we doing to make certain that babies can be born healthy in this community? And do we cry when babies are born? Or more importantly, in this community, do we cry when some of them die?
Let's talk about co-sleeping. We had another death within the last week. An infant, I think her mother fell asleep on the couch, and the child became trapped in the couch and died. We'd like to say this is an unusual occurrence, but unfortunately it's been too common in this city over the last few years. I know you're working hard to address that problem. What needs to be done? What is being done?
Well, let's first be, again, candid about the controversy on different methods to address this issue. Outside of probably football, it's the most visceral of discussions that I've had during my 12 years here in Milwaukee. And that's because it is about human life, and there are many things that hang in the balance. There is nothing more impenetrable, more delicate, more incredible than the bond between mother and child. And understanding that nurturing, bonding, and sleeping with the child has been happening for centuries. It invokes a lot of emotions when we look at this issue of co-sleeping. I believe that there is no greater pain than a mother or father to lose a child, and the whole world should weep. And perhaps some of the techniques to avoid that, while we change and swing the pendulum of understanding in this community, why it happens more here, there are many reasons, but to not have that happen, to not put oneself in a position, to put that baby in the room and to put them close in a bassinet and to not have that happen. I don't know all of the reasons it happens. But I do think what's happened is that the lines have been drawn in terms of race and class, culture, and those are bad people. I've looked into the eyes of some of these mothers. I've reviewed every death, and it's about 100 of them a year, infant deaths, about 20% of those could be to unsafe sleep positions. And I've read child death reviews from the coroner and from many of the nurses and midwives and others who've written. Not one single time have I ever seen written or said that the mother didn't love her child. These are tragic things that are happening. But they seem to happen more here in Wisconsin. So we need to deal with that. We need to confront that. We need to be real about why it happens here. We need to be real. This is a slow motion Sandy Hook. This is a slow motion what's happening in Chicago. Yes, it's 18, 19 deaths, but it's happening over and over again. And what can we do about it? Have you done enough? Have I done enough?
What are we doing about it?
Well, I think what we're doing is certainly at the city level, and again, we're one nugget of this. There is a role for government. We're not the only role. We are fashioning awareness and giving the opportunity for individuals who can't afford a safe place, and we'll give them a crib. And yes, we've been sort of criticized for our messaging, and there was even some discussion about criminalizing this process. If I went home and one of my children wasn't there, and they had succumbed, and through the grace of God they had moved on, and someone wanted to arrest me because it was a tragic accident, I have a lifetime of pain. I have my own purgatory right here in Milwaukee if one of my children were to die. Why would I pour gasoline on top of that? I mean, what does that do? Does it make you feel better, me feel better, to lock one of these mothers up? I leave that to the district attorney. I do believe that there are individuals in this community who are doing what my grandmother did. My grandmother was a grand midwife. She did midwifery in rural North Carolina for 59 years. You have to be 50 years of midwifery to be a grand midwife. So for 59 years, she delivered babies in rural North Carolina. I asked her one day, at 12 years old, Grandma, why is it that some babies die and others live? And she looked at me with only the wisdom that a grandmother could do, and she said, simply, your responsibility is to take care of the ones that live. God will take care of the ones that die. So is this community taking care of those babies? The babies that have those babies who die from unsafe sleep positions. Have we done enough to that young woman who may have 2 kids who are tired? My own wife and I were just immensely tired when we had our daughter. We don't know how we did it. It was in an IV pole of energy in our bedroom. We needed it. And we were 2 parents. Sometimes these are single parents. They're trying to do the best they can. But have we as a community done enough? Is this Milwaukee's dirty linen? How shall we clean it?
Let me push back on that, though, for a moment, because we heard from one of the city's aldermen, Bob Donovan, in the past week, who said, based on what he knew about this latest incident, and of course it's still being investigated, but there seemed to be an indication of drinking having taken place, perhaps mixing with prescription medicine, and that behavior in the presence of an infant of that kind could be criminal, that it results in neglect in a certain way. That if you held someone accountable, this is his argument, if you held someone accountable, perhaps that acts as a deterrent to others, to emphasize the seriousness of what has occurred. What's your reaction to that?
Well, I certainly, again, I mentioned earlier, there's always a role for government when we look at health, and government officials are going to comment on issues and matters of health. But there have been, and there are, laws on the book that deal with child neglect and abuse. And I believe that the criminal justice system and the legal system is well equipped to invoke those laws to deal with cases where neglect and abuse are obvious. This is not about cutting hairs. This is not about splitting atoms and saying that this rises to a level of criminality where we have to have additional laws. The issue is whether or not we are invoking the statutes that are on the books and the laws. And I do believe that we have a great criminal justice system. We have a district attorney and a great staff who can make those types of of decisions. You know, one of the things I did, and there have been 16 health commissioners in the history of Milwaukee, and one of the things I did when I first took that post was to go back and read the memoirs of all of the health commissioners before me. And I got to one, and it was one night I was up really late reading, and there was a health commissioner who actually, and this is still on the books, so be careful, but there is a law on the books right now in Milwaukee called the Ugly Child Law. And it was a law that the health commissioner had powers to stop people on the street, to go into homes, and literally pull a child out of the house and take them away to a sanatorium or a hospital because they were ugly. Now, granted, that's the way it was written into the legal language, but it was because of cleft palate. And the feeling back then was because these kids had deformities, that they caused problems in society. Well, we don't invoke the ugly child law. I had that power as health commissioner in public health statute. And I've seen some ugly children. But I never will invoke that law. Because I believe that we have societal norms. And I believe that there are conditions where we invoke laws to take care of those matters. And I think on this occasion, the district attorney has within his power the ability to look at child neglect laws. And I have within my power to look at the ugly child law. I've chosen not to do it.
This infant mortality issue is huge. How optimistic are you that in the next 5 years or so we're going to see dramatic progress on that front?
Well, I am. I mean, let me say, and as a transplant here in Wisconsin, it was difficult for me until I got here and began to work in public health and community health to understand the true enormity of what it is we're trying to fix here. You just don't know. You land at Mitchell, there's not a welcoming sign from the Commerce Department saying, "Welcome to Milwaukee, one of the cities with one of the highest black infant mortality rates in the nation." You just don't know it. Wisconsin has kept that close. Milwaukee's kept it even closer. I think this is a generational thing. I mean, I think it will probably take a generation or so for us to change these statistics, to create a condition of health equity where everyone has an equal chance for a good birth outcome. And I think 5 years we might come to an agreement, but we will not come to a solution.
I use 5 years as an example in part because in 5 years, 5 short years, there has been dramatic progress made on the issue of teen pregnancy in this community. A lot of different parties sat down in Milwaukee and said, we have to do something about this. Again, we had a rate that was certainly one that we should all be concerned about. And the teenage pregnancy rate has dropped how much in the last 5 years? It's dropped dramatically.
It's dramatically. Our goal was by 2015,
almost 50%,
to get to 46%. We dropped nearly 33%, and we're on target to make that goal as a community. Here's the difference. And certainly there are a tremendous group of people who are working on this. Every woman in this room has been a 13-year-old girl. Let me say that again. Every woman in this room has been a 13-year-old girl. And every man in this room has seen, know a 13-year-old girl. And we all know that what sense is it that a 13-year-old girl in Milwaukee could be, and has many times, having her second baby? I rounded at one of our facilities not far from here about 7 years ago, and I saw an 11-year-old girl give birth to a baby. Remarkable. But what was most remarkable was that it was her second baby. She had delivered the first at 10 years old. A line had been drawn in the sand, and in agape fashion, this community had come together and said no mas. We had taken the construct of race, class, all of the issues that were keeping Milwaukee from dealing with this 30-year issue and said, enough. We have not gotten there with infant mortality. Because everyone who's a 13-year-old girl or woman can relate to the vulnerability of someone being pregnant as a teenager. Every father could relate to the fact that their 12-year-old daughter could be and was victimized in order to become pregnant. But when it comes to infant mortality, it's not contagious. You can't catch it. It's those people. And how do we connect that fabric? Even an adoptive mother has a virtual wound. And they feel for mothers who actually carry a baby through pregnancy. But this community has not, it hadn't gotten the empathy to say, enough. 100 babies is not enough. There are more babies who die as a result of infant mortality than there are homicides. And it's been that way annually for 6 consecutive years. Yet, homicides make the front page. And to Journal Sentinel's credit, the Empty Cradle series has put infant deaths on the front page, but it's on the front pages of our paper, but not on the back pages of our hearts.
So this is a tougher one to solve.
It is a tougher one to solve because when we go home and we hug our own children, we kiss our own grandchildren, we look in the eyes of babies, it's ours. And those people die. I can't imagine the wailing. My own mother and I had a brother who died at birth. And my mother passed away a few years ago. And she was north of 80 years old. I'm north of 50. She never mentioned my brother's name in all of my life. And the pain was too great. He died 4 hours after being born. She never mentioned his name for 53 years. So the pain of losing a baby is a lifetime thing. And where's our compassion? So I don't know. I know Harlem, when I lived in New York City, there was a published report that a child growing up in Harlem had less probability of living to age 18 than a kid growing up in Beirut, Lebanon. And Harlem and New York City decided enough. And now they have one of the lowest black infant mortality rates in the country. And if they could do it, then certainly Milwaukee can. But it took them a while, and it took investments from traditional and non-traditional partners. It took the faith community, the business community. It took everybody working on this issue.
There seems to be a growing school of thought that violence, more specifically, I guess gun violence, that violence is a public health issue. You're one of those who believes that. Why do you see it that way?
Well, I think that in the history of our civilization, any threat to our existence and our survival has been approached in the same fashion as we do any other disease. We have got to look at it as a population health issue. When you have that many individuals that are succumbing to violence, a condition of violence, and an environmental issue, we've got to go upstream and deal with it as we would any other disease. We have to attack it the same way we do infant mortality, the same way we do teen pregnancy, the same way we do chronic disease. It is permeating in our community. The techniques that we use to deal with other public health conditions can and will be successful when looking at violence as a public health concern. Now, there is tremendous discourse now about gun control and gun advocacy and NRA and all of those things. And it doesn't matter whether you're left or right or center. What matters is, what does this community's conscience say we should do when it comes to the issue of violence? And what type of legacy do we leave for those who follow us if they are born into and inherit a community, a city, a state, and a nation of violence? We can look at National Geographic and see images of where we assume that they're savages because there's violence and someone is filming it. What if we were in a position where someone was filming us unbeknownst to us? Would they think that we're savages because of the violence that exists? Perhaps. We've got to look at violence as a public health concern. And there is not enough that one could do. We could police everything, but we can't police the mind, the body, and the spirits and the hearts of individuals. That has to be about going upstream and dealing with those issues from a public health and population health concern.
So give me an example of what the city health department can do. If you see this as a public health issue, what can your department do to affect the outcomes?
Well, I think one of the things that we've been able to do, and certainly through the leadership of Mayor Barrett, first creating an Office of Violence Prevention and sitting it in the Milwaukee Health Department, one of the few health departments in the nation that actually has that infrastructure. We can begin to look at public policy. We can begin to look at data warehousing and data sharing. We can look at homicide review. We can have a relationship with law enforcement, with the legal and justice system, to begin to look into the genetic side of the incendiary process of violence, and then provide that information back to those. We can look at every single rape, every single case of domestic abuse, and begin to come up with techniques, and then we can, from a public health standpoint, find out about those partners who can give and are a part of the system that fixes this. I think we're doing that. Data is our friend here.
So data collection is a big part of what you can do to help make sure that the people who could affect change can know where to do
it is the epidemiology of disease. It's the same way that we look at disease manifestation. If there was a disease that was impacting you or your family, wouldn't you want every part of that disease researched? Wouldn't you want to know? I mean, you see websites, you see fundraising for diseases and someone gets the passion and they create foundation that said, we're going to figure out how this particular melanoma kills. No one knows, and then all of a sudden, 20 years later, they have $500 million endowment. Well, what if we were to get people to say, well, what is it? Why does Milwaukee have more illegal guns on the street than other cities of similar size? Can't we research why? Can't we get to the bottom of that? I don't know a 15-year-old in this country that could fly an airplane to Germany, pick up Glocks, and bring them here and drop them off on the north side or the south side of Milwaukee. They're not doing it, but they have them. So we could trace how that happens. And we could do that through the epidemiology of understanding violence and how it permeates communities.
It's kind of interesting hearing you talk about this, because you obviously envision a very proactive role for the health department. I hear you talk sometimes about, and this may not be all that well known in this room, but about how people from the city health department, I mean, they're going into homes, they're visiting neighborhoods, visiting people. It's a very personal, one-on-one approach to public health. Is that your philosophy, or how did you arrive at doing this? And give us some examples of what your people are doing in the field.
Well, I think that I certainly bought that philosophy. One of the things that I noticed, and certainly health commissioners before me, they had the good fortune and the wherewithal to make certain that every single baby born in the city got a visit from a nurse. And those of us who are old enough to remember, it happened. You know, there was a nurse, and they had a nice uniform, and they came, and they knocked on the door, and they said, we know that a baby's in this home, and we want to make sure that they're okay. And we'd gotten away from that. Society wasn't funding that. And then it became vogue again to do that. And we have programs like the Nurse Family Partnership, the Empowering Milwaukee Families program in our health department, where we visit those high-risk babies, high-risk mothers in neighborhoods where there's high rates of unemployment, low academic achievement, and there's violence there. And we make certain we get relationships with those women. As soon as we know that they're pregnant, preconceptually, we want to know that we can be there to case manage them. And that's the old way it was done. My grandmother did that. She did that through rural farms in North Carolina. You know, and she visited people, and as soon as they found out that someone 5 miles down the road was going to have a baby, she made 6 or 7 visits there. She made certain that there was enough food there. She made certain that the husband was still working, or could they do the things that they needed to do. And she didn't worry about how much she got paid or whether even she got paid. But when that baby was born, the whole community exhaled. It was a great thing. And that's something that the Milwaukee Health Department is doing. But it's not easy. And it is tough. And these nurses see things that one shouldn't see. You know, 2.5 years ago, I and Mayor Barrett and Council President Hines, we were on the phone one late evening, and we were calling nurses. And it was 2 of our young public health nurses who had made home visits and had gotten caught in a shootout right into the kitchen of one of the mothers that they were visiting. Bullets flying. They hit the deck. One of them had been on the job 2 days. She's still with us today. And I remembered calling her. And I said, what did they teach this in nursing home? Did they teach you, in nursing school rather? Did they teach you how to dodge bullets? But that is Milwaukee. And this is happening. It's happening in Syria. It's happening in Iran. It's happening in the Congo. There are nurses. There are peace workers. There's physicians who are going into homes and villages to make certain that babies survive. It's happening here in Milwaukee, and we are oblivious of it. We look at tertiary care outcomes. We have one of the best health care delivery systems in the nation in terms of quality. But yet we have some of the worst public health outcomes. How's that? How does that jive?
And you said that's a fairly recent phenomenon. I think I've also heard you say that not all that long ago, Milwaukee was considered one of the healthiest cities in the country. Is that true?
It was, and there was a book written to this issue, and there was a contest that was held annually. For so many years, Milwaukee had won this over and over again that they did away with it, and it was the healthiest city. And Milwaukee, if you go back through the annals of history, it was one of those cities. It was a great city by the lake that began to take its health seriously. When there were communities all up and down the Great Lakes that were dying from typhoid and diphtheria, New York had the flu that really impacted them in great ways. But here in Milwaukee, they didn't have the same number of deaths from typhoid and influenza because they were one of the first cities, one of the oldest cities to have health commissioners. 1867, we've been along. They realized that the water needed to be safe. They realized we needed to have universal precautions. We realized that we needed to do those things. So it was the healthiest city. Commerce grew here because it was a healthy city. I said earlier, if a city is not healthy, it's not relevant. What made Milwaukee great? What made Wisconsin great? What made the Wisconsin idea come to life was that Wisconsin was healthy. And what I cannot understand is how in this state, here in southeastern Wisconsin, where most of the population exists and most of the health issues exist, why there isn't greater focus to make Milwaukee healthy, then make Wisconsin more relevant. I don't understand that. So I've lived a lot of places in this nation. I've lived outside of the country. And every place that I lived, the state made certain that that city was relevant and healthy so the state could be better. But here in Wisconsin, there appears to be a veil, and it starts at the county line in terms of relevancy. And I don't understand that.
I did want to ask one more question, then we'll take your questions from the audience. But it deals with the fact that you have lived other places. And we've heard you describe some of the serious challenges facing this community. And yet, you're very bullish on Milwaukee. You and your wife, I mean, have lived here, made it your home. You've stayed more than a decade. Give us your observations about this city. You've been in places like New York and Miami before you came here. What is it about Milwaukee that has become, something that you feel very fondly about?
Well, it is true. When you move from Miami in the heart of winter, it's 86 degrees, and you land at Metro and there's 52 inches of snow on the ground and it's -4, and you look at your spouse and they say, you are a genius. And but here, fast forward some 15 years, what I love about this city and what I love about this state, and I've lived even in Europe for a while, and my wife was born in the British Islands, is that Milwaukee has the most potential of any place that we've ever lived. And more than Miami, more than New York, more than Pittsburgh, more than Rotterdam in the Netherlands where I lived for a while, because it has that potential, it keeps us coming back. The issue that I have as an academician, as a health commissioner, as someone who's looking at our community, is our inability to quickly embrace what could make us move to the next level. And what would make us move to the next level to be a first-class city, revered like a New York or San Francisco or Miami or whatever the other big cities out there that are sometimes revered, is we must begin to embrace the diversity and have inclusivity so that it will bring about even more greatness. Those cities are great because they have embraced diversity. They still have fisters and sores and problems, but that's character where I'm from. We are spotless, and maybe we look good on the outside, but it is character that draws you back to something. It is that imperfection that makes Milwaukee attractive. It is the undeniable ability of Milwaukee to always try to claw its way to be great. And I believe, and my wife believes, and now my children believe, that this is truly a great city by the lake that's trying to claw itself to greatness. And to do that, we have got to do what other cities have done. And that is to address race, to address poverty, to look at these issues and say, it is tough, it is unimaginable, it makes me sick, it is ugly. But to be great, we have got to do the unimaginable thing, and that is to once and for all to say, in a true fashion, to take our spiritual and our moral compass and say, Milwaukee will not be the healthiest, greatest, most relevant city in America until we deal with our dirty linen. And that's what New York has done. That's what Miami is trying to do. And that's what other cities in this nation that I lived in have done. And they're not perfect, but they are addressing those issues. So Milwaukee just keeps us coming back. It can be, it will be great, but it will not be the greatest city that it can be until we are honest about diversity, inclusion, and our spiritual and moral compass. I believe there's a social covenant that has been broken, and it wasn't always this way. We've got to bring that covenant back, and that means we've got to have a moment where we say, you know what, black, brown, white, whatever it may be, Milwaukee is better than this.
Mm-hmm. Let me take questions from the audience. I'd ask you in the seating bowl, you see these little buttons in front of you. Hold down the rim. Just keep your finger pressed down on the rim, and we'll all be able to hear your questions. Those of you in the back, shout really loudly. So raise your hand. Keep your questions brief. We'll get to as many as possible. You bet.
Doctor, I think you were asked earlier by Mr. Boucher about the possible deterrent effect of prosecutions in this infant death situation. And I'm looking particularly at the one that just happened last week, where it's right fresh in my mind. It seems to me, and I'm a retired lawyer with some long time ago prosecutorial and defense practice, that if this woman, this mother who essentially smothered her week-old infant after drinking and, according to the paper, at least taking some drugs with it and falling asleep, if she were prosecuted and perhaps even had to serve some time, that this would get a fair amount of publicity, television, newspaper, and word of mouth. And I just have to think that that alone would deter some people from engaging in the conduct that led to this, the drinking. I'm not talking about co-sleeping where you consciously bring your baby into bed with you. That's maybe a cultural thing. But something like this where a mom essentially collapses on her sofa and smothers her infant. Shouldn't your office be lobbying, or at least in communication with the district attorney's office, to pursue a prosecution in a case like the one we were just reading about?
I appreciate the theoretical nature of what you said. And my office has been and still is in contact with the district attorney on these matters, and we do have dialogue. And heretofore, they have not moved in that direction, and I don't support them moving in that direction. But with that being said, there is a reciprocal relationship between invoking prosecutorial techniques to change societal norms. Why doesn't this exist in other places in the country? And why don't they have rigid laws? I know Texas has done this, and a few other cities have these laws on the books where they give breathalyzers to the mother whenever there is a incident where there is a sleep-related death. But if it's not in every other major city, Milwaukee is one of the top 40 largest cities. We're number 29 right now. If other cities don't have it, why does Milwaukee need it? What is different here? What requires us to invoke that part of law that other communities don't have? And I would rather deal with this in the daylight than in the shadows where people begin to go underground and address this issue. Because I think what you will get is mothers who will hesitate calling 911, where a baby could have been or may be revived or could get care until they fix a proposed crime scene, until she gets sober 8 hours later, and then there's no way that she could be charged with that. So it's complex, and I do know that there's a bill being pushed, or at least I've reviewed it, and I've talked with a district attorney outside of Milwaukee who has contacted my office, and there's a representative who's outside of Milwaukee who's considering this. So I understand it, but I do think it has layers of complexity, and the least of which would be, do we push something further underground? And again, I think the more discourse we have about this might work. But I reviewed to see how many other cities have that law, and it's only 3 that have actually prosecuted someone in the last 10 years for this, outside of traditional child abuse and neglect laws.
Let me take other questions. Please raise your hand. We'll go right here. Yes.
In Milwaukee, we have.
There you go.
In Milwaukee, we have 4 federally qualified community health centers, and they partner with different networks in our community to help with mortality. We focus on, OBGYN services as well as women's health. And we're wondering, with the limited funds that we do have to do outreach, how do you see the message of the available care to those who don't receive or who don't know about that care in the inner city? How do you see us being able to provide that outreach for those who don't know?
Okay. Well, I think that's a very critical issue, and I think that access is always going to permeate and be part of a solution to great population health outcomes. Federally qualified health centers are important. I've worked in that environment when I was in Florida. I think that their expansion and our support of them is needed, and we need to invest into them and other community healthcare clinics within our region and our state. But here's where it becomes a challenge. Now, Milwaukee has great access. We even had great insurance coverage. We had about 94% insurance coverage for many years, but we still have chronic disease management issues, hypertension, diabetes, we have, obesity, all those things. Access is important, but public health is about prevention. If you go back and look at before we had these great meccas of modern technology in terms of healthcare, one had to look at prevention, because either you couldn't afford to go to the doctor because of finances, or there wasn't one in your remote regions of wherever you live. So we've got to look at prevention. I'm more concerned with having those access portals there, but really teaching people to deal with nutrition, to deal with vaccine preventable disease, to deal with health, and to begin to embrace prevention as a way to curb things. And I think that's on the way. And whether you agree with the Affordable Care Act and what's going to happen in 2014, there's some good stuff there and there's some bad stuff there, but I think the good outweighs the bad in terms of how that law might actually address some of those issues, including community health center expansion. There's about $3 billion that would be invoked as a part of the Affordable Care Act.
Let me go here. Yes.
So, Mr. Health Commissioner, our fundamental problem, according to the Institute of Medicine, is that public health is grossly underfunded. And they compare us to other countries with very low life expectancies, and those are countries like Mexico and Turkey, where the expenditures on medical care far outstrip the expenditures on health care other forms of sustaining healthcare. Is there a formula where we can move our country forward in identifying that a dollar spent now is worth $2,000 later, and we can start to make that transition? Because that seems to be what's lacking here is that's always the quote, the infrastructure you pay for when things are good. I think that's the prosperous world kind of view, which is this public health is what you spend money on when you've taken care of other things. And we just have avoided that process for a long time. I mean, the IOM report recommended a tax on healthcare to support public health and preventative health care. Let's say.
Well, I appreciate that, and thank you for referencing the Institute of Medicine report. Let's start with Wisconsin, though, before we deal with the nation. We rank 49th in public health funding in the state, and it's been that way for several decades. So you can talk about how great Wisconsin is and how healthy it is, but we put less money from the GPR into public health financing than every other state except Mississippi. So it's it's not what you get, it's what you do with what you get that matters. And we get a lot of tax dollars. So reinvesting that into to provide a social contract. There's a social contract when you go to your neighborhood store to purchase food, that food is safe and it's been grown and it's not going to make you sick. There's a social contract when you get on a bus or if you go to a ball game, that the person next to you, even if they have a disease, that disease is probably going to be something that wouldn't kill you immediately, because public health is dealing with disease that's circulating. We're surveilling disease. So until we decide that it's more important to go upstream and deal with healthy outcomes than to elongate life through tertiary care life-sustaining methods. We all believe, just get me to the hospital. It's much like the old Western Gunsmoke. Just patch me up, doc, pour some alcohol on it, and I'll be on my way. But if we were to deal with those things that can kill our community, it goes back to that moral, spiritual, and social covenant. Public health is just that. It is a social, moral, and spiritual covenant that each and every one of us in this room has an equal opportunity to be healthy. Cancer may kill me, but it's not because I don't. It should be more because of what it does to myself and less about where I'm born, how I'm born, and what I look like. And that's public health. So until we scream that that's what we want, and while we succumb to a stadium tax to make certain we can root for the team, and people pay that, when will you pay a tax to make certain that we all have an equal chance to be healthy? So I agree with you, but this is really about everyone deciding what's important.
So a question over here, yes.
What the outcome was of the ads that you ran. You said, dealing with it during the daytime. And here were these powerful ads with a baby and a knife or a gun next to it and said, would you put this next to your baby? And yet it was the idea of parents sleeping next to their baby. And they weren't ever out very long. I saw it at a bus stop, and the next thing it was gone. And what was the response to that?
Well,
they were provocative ads, and they were controversial ads.
They were controversial. I think I received more media attention from that ad, and certainly BBC Today, Brazil Today, Good Morning America. The list goes on in terms of those that were concerned about that. And while it was a guerrilla tactic, people completely missed the point here.
Describe the image for people who have not seen the ad. It shows an infant, and it shows, is it a meat cleaver?
It was a meat cleaver.
Next to it.
It was next to the
on
pillow,
its side,
and it
next to the infant.
And said, sleeping with your baby could be just as dangerous. We actually received the Clio Award, which is a marketing award for that ad, which we competed worldwide against Nike, Coca-Cola, and some other major business entities. And we won in terms of what it did. It was to create an environment of dialogue, and to bring this out of the shadows. We're not going to run that ad again. It was too controversial, and many may have thought that we overstepped our bounds. I will make apologies for an ad that didn't work, but I will make no apologies for not advocating for the babies that die in this community. And I think that's what was missed here. So was it effective? I don't know. But I do know it got people talking about it. Milwaukee, again, going back to my earlier statement, if you're unhealthy, you're not relevant. We were relevant when the whole world was talking about that ad. They knew that there was something happening with babies dying here in Milwaukee. Then the light bulb went off. And now we fought internally as a community about that was the wrong thing. It was just too visceral. It's too guerrilla. But no, a baby dying is never right. Sandy Hook is creating virtual battle lines now. You know, and whether you agree with one or the other side of the ledger, the bottom line is that there were babies with their face blown off. One of the kids, his mother did an Emmett Till moment. She let his coffin be open so everyone could see that his face was blown off from the nose down. And that happened. So she got response from the Connecticut legislator. What will it take to get a response from our legislature to deal with infant mortality, to make it the top priority of this state? Do we have to have open coffins to do that? Do we need billboards that shows the actual dead body? I don't know. And I'm not advocating that. What I am saying, it goes back to the social, moral, and spiritual covenant of what this community is. We're only as healthy as our conscience.
We take one or two more questions. Yes.
Will you give us the nitty-grit of City of Milwaukee, our town, in terms of your budget this year, how many people are working in the department, and how that budget is divided up and prioritized?
Well, that's public information, and I think that we are learning. We have about 256 full-time employees, and we can flex out to about 300 in the summer with population health fellows and physicians and nurses and nursing students and others who rotate through. We are 52% grant funded. So I always say that we're a good deal for our taxing authority, because they're going to get 1.5 back for every dollar that they give us. So we rely heavily on grants. But we become more efficient. When I became health commissioner, one of the first things I told my team is that we cannot and should not be your grandmother's health department. We need to level the playing field. Why can't we be the best health department in the nation? And we are going to be, and we will be. One, because we are an academic health department. We need to have a three-legged stool: teaching, research, and care. And I believe in that, and that's what we're doing. We have relationships with every institution of higher learning, including this one in this region. We are in the new School of Public Health, the Zilber School. We actually have a third floor there, and we have up to 30 of our staff actually sit there, so we can be down the hall from researchers. We are using the tenets of a digital democracy to work better, work faster. We're seeing students who come in that are brighter, who can look at technology as our friend. The things that our nurses and our sanitarians and our inspectors and our laboratory scientists who are dealing with molecular techniques versus regular laboratory assays, we are able to do things that we couldn't do. But at the end of the day, there's one thing that we do at the Milwaukee Health Department that's more important than anything. I could have 1,000 employees. I could have 10 times the budget. There's the one thing that we have, and the one thing I hope we never lose, is that we have the community's trust. You trust that public health is going to be there. Public health is the refrigerator light of your community. When you open the door to your refrigerator, the light comes on and you don't think about it. And you open it 10,000 times. The first time you open the door and the light doesn't come on, the first thing you want to know is what's wrong with the refrigerator light. You have got to replace the light bulb. And that's why we're where we are in public health. You've got to fund us and replace our light bulb. But we have your commitment, to be citizens, and you have our trust to always be that refrigerator light. And that's where our Milwaukee Health Department is. We're one of the oldest in the nation, and we hope to be here another 150 years.
I've got about 30 seconds left. The light bulb went on for you at some point when you decided public health was your career. Picked up your master's at the University of Virginia in public health administration, and you decided this was going to be your life's work. Mm-hmm. What was it? Was there a moment that caused you to say, this is what I want to do?
Yeah. Well, I think there was a moment. It is great that I'm sitting in the Hallow Halls of Marquette University, and as a small child, and when my parents were both overseas doing mission work, and I couldn't understand why we were in Mozambique in a tent when my mother was there and my father was there, and they were providing care. And I said, I just want to get out of here. I want to be a regular boy. But it's a calling, and you have an obligation to your community. I will never make $1 million, but I won't starve to death. The greatest legacy that I could ever leave to myself, my family, and my community is to serve. There's nothing more noble. And once you catch the public health bug, no pun intended, you will always be committed to the community. What kind of mother, father, sister, brother, uncle, aunt would you be if you didn't care as much about your community as you cared about yourself? I care about this community, and I'm glad that public health chose me.
Milwaukee Health Commissioner Bevan Baker, thanks so much for being with us.
Thank you.
Hang on one second.
Thank you.